Welcome to the Basics of Pharmacology. I hope you are having a great day. We are going to review some of the basics of prescribing drugs. The definition of pharmacology comes from two words that ultimately means the study of medicine. Pharmacology is defined actually as the study of drugs and drug action. Being a prescriber has an enormous responsibility. There is a difference between giving drugs as a registered nurse and prescribing them. Again, I realize that all of you in this class are not going to be nurse practitioners, but the class is to be equal in case you change your mind later. All substances can be toxic under certain circumstances, even water, but medications have a much narrower index for toxicity. Drugs have many names. The chemical name includes information on the drug's molecular structure. We're not going to be paying too much attention to this name. The trivial name is the common name, and it sometimes arises from historical uses, predating the use of formal naming conventions. An example of that is acetylsalicylic acid, or ASA, for aspirin. We're not going to be using this name much either. The generic name is a non-proprietary drug name adopted by an official recognized organization within each country. Within the U.S., this is indicated by the drug's United States adopted name, which is assigned by a joint council co-sponsored by the American Medical Association, United States Pharmacopeal Convention, and the American Pharmacist Association. Other countries have their own independent organizations, which sometimes adopt names that differ from those used in the U.S. The trade name is the name for a drug whose formula and/or mode of manufacture is owned by a corporation under a patent or registered trademark. And this can result in multiple trade names for the same active ingredient. Due to the fact that drugs can have many trade names, pharmacologists most commonly refer to drugs by their non-proprietary generic name and not by their trade names. This is also true for test questions on standardized exams where only generic drug names are used. We will be using mostly generic names in this class, and testing will be on the generic names. Although patents are good for 20 years after the invention of the drug, it can take up to 8 years for a pharmaceutical company to do enough testing for approval from the U.S. Food and Drug Administration and investors. This is because the FDA can continuously ask for more studies and experiments that document the side effects and efficacy on human patients. It is estimated that once a generic drug hits the market after a patent expiration, name brand sales drop by 80%. In 1984, the government passed the Drug Price Competition and Patent Term Restoration Act, also known as the Hatch-Waxman Act. This act gave patent extensions to name brand drug companies to compensate for delays in the FDA approval process. This allows for a patent extension for up to 5 years, regardless of the length of time it took for the FDA to approve the drug. The act further caps the protected amount of time to 14 years, depending on the approval delay timeframe. This ensures that the patent holder can assume profitability before generic drug companies move into the picture. In addition, a 3-year extension can be earned by extending the period of effectiveness. For example, Adderall XR a reformulation of the already patented drug Adderall, improves on its predecessor by offering an extended period of effectiveness. Second way to get that 3-year extension is administering a drug in a new way. Imitrex, a migraine drug originally sold in tablet form, was later reformulated and patented for intranasal delivery. And a third way to get that 3-year extension is making the drug more effective. This can take the form of reducing the dosage while increasing the bioavailability and or reducing adverse side effects. The drug Nexium is a version of the drug Prilosec that only includes the effective form of the active molecule. No drug affects only one receptor. Thus, no drug has a single specific effect, which is why all drugs have side effects. Some people may not experience them, while others do. This is the clinical trial process for a new drug to be approved by the FDA. Clinical trials, which begin only after the FDA grants approval for investigation, consists of 4 phases and may last up to 9 years before a drug is approved for general use. During clinical trials performed on healthy volunteers, data are gathered about the proposed drug's purity, bioavailability, potency, efficacy, safety, and toxicity. Phase 1 of clinical trials is the initial evaluation of the drug. It involves supervised studies on 20 to 100 healthy people and focuses on the absorption, distribution, metabolism, and elimination of the drug. In Phase 1, the most effective administration routes and dosage ranges are determined. During Phase 2, up to several hundred patients with the disease for which the drug is intended are subjects. The testing focus is the same as in Phase 1, except that the drug effects are monitored on people with disease. Phase 3 begins once the FDA determines that the drug causes no apparent serious adverse effects and that the dosage range is appropriate. Double-blind research methods are used for data collection in this phase, and the proposed drug is compared with a placebo. Usually, several thousand subjects are involved in this phase, which lasts several years and during which most risks of the proposed drug is discovered. At the completion of Phase 3, the FDA evaluates data presented and accepts or rejects the application for the new drug. Approval of the application means that the drug can be marketed, but only by the company seeking approval. Once on the market, the drug enters Phase 4, or post-marketing surveillance. Objectives at this stage are to compare the drug with others on the market, to monitor for long-term effectiveness and impact on quality of life, and to analyze cost effectiveness. During post-marketing surveillance, drugs can be taken off the market or restricted due to additional findings about the drug and side effects. The passage of the Currently, DEA numbers are required to prescribe controlled substances. The ability of APRNs to order controlled substances varies state by state. In Illinois, APNs are allowed to order Schedule 2 through 5 drugs. However, there must be a collaborating physician for Schedule II, and APRNs may only prescribe a 30-day supply, with any continuation authorized only after discussion and prior approval by the collaborating physician. The state license to prescribe medications or drugs is inexpensive, but the controlled substance license from the DEA costs about $750 every 2 years. It's every 3 years. Usually, your collaborating physician or employer pays for this, but after obtaining full practice authority, it will probably be the APRN's responsibility. A Universal National Provider Identification Number was adopted by the Secretary of HHS in January 2006. It is anticipated that this will eventually include the DEA numbers, but has not yet. These are the purposes of the National Provider Identifier. Mostly it's used to identify the healthcare provider for insurance, claims, and prescriptions. Your individual NPI is yours, even if your employer files the application for it. The NPI does not change when you change practices or work in different settings. You will only have one individual NPI. It will be used by all health plans who are covered entities, eliminating what are likely many provider numbers assigned by Medicare, Medicaid, and private payers at present. It is prudent to not prescribe to friends, family, or self. For safety purposes, you need a thorough history and physical examination before prescribing anything. You might think you know everything about your family and friends, but do you really know their physical condition, all of their medical history, and current medications? If you are missing any portion of these items, your prescription may have devastating effects. This resultantly increases your liability. Thus, you need to have a documented provider-patient relationship with the person for whom you are prescribing. At each visit, a medication history is obtained with the name of the drug, dosage, and frequency of administration. Information on any allergies should also be obtained. It is also helpful if the patient brings his or her actual drugs to the visit. Multiple steps are involved in prescribing drugs and evaluating their effectiveness. Again, the first step is determining an accurate diagnosis based on the patient's history, physical examination, and pertinent test findings. Next, in selecting the best agent, the practitioner thoroughly evaluates the patient's conditions, taking into consideration the effect that various medications may have on the patient and the disorder, the expected outcomes of therapy, and other variables. When prescribing any drug therapy, the practitioner must have a solid knowledge and background in pathophysiology of disease, pharmacotherapeutics, pharmacokinetics, pharmacodynamics, and any interactions. The United States, which leaves pricing to market competition, has higher drug prices than other countries where governments directly or indirectly control medicine costs. That makes it by far the most profitable market for pharmaceutical companies, leading to complaints that Americans are effectively subsidizing health systems elsewhere. Manufacturers say decent returns are needed to reward high-risk research, and prices reflect the economic value provided by medicines. They also point to higher U.S. survival rates for diseases such as cancer and the availability of industry-backed access schemes for poor citizens. When patients cannot afford the drug you prescribe, they may not get well, even though they want to be compliant. It is of critical importance that providers ask patients if they have difficulty obtaining their medication because it is cost prohibitive. My patients offer this information freely. I have many patients who are uninsured or underinsured, as well as many patients on Medicare Part D. My first go-to is the $4 drug list. This drug list was originally developed by Walmart for many of the most common generic drugs prescribed. Most pharmacies either match this list or have a similar list of their own. I've posted this list. In my office, we also have drug samples for many of the newer drugs that we can give the patients. Because my office is in a rural area, we also operate a very limited pharmacy where we sell some of the most common drugs and antibiotics at $2 or $3 above cost. Seeing what our cost is makes me understand why there's a pharmacy on nearly every corner in the U.S. Drugs do have quite a markup. For example, azithromycin or a Z-Pak is $10 at my office. Acetylopram, can't even say it right, or Lexapro is $20 for 100 pills or 100 days. We offer rosuvastatin, which is Crestor, for $26 for 100 days. If you find that your patient is having difficulty purchasing the prescribed drugs, consider changing pharmacies or drug regimens. The cost of a drug can vary widely between pharmacies, even within the same city. I use the app GoodRx if patients need to pay for their medications out of pocket. There are other apps available. I also wanted to mention the donut hole. For the year 2019, Medicare Part D beneficiaries pay their deductible, if applicable, and their copays until the costs reach $3,820 for their prescription medications. This isn't their out-of-pocket cost, but the total cost of the medication. The out-of-pocket cost may be quite a bit lower. The coverage gap or donut hole begins when the patient's yearly prescription drug costs are more than $3,820. Again, this is for 2019. Keep in mind this number includes what they have paid out of pocket plus the cost the insurance has paid. During the donut hole, most patients will pay no more than 25% of brand name drug costs and 37% of generic drug costs, up to $1,500 before catastrophic coverage kicks in, and the patient only has to pay up to 5% of all drug costs. By 2020, the amount patients will have to pay for generic drugs during the donut hole will decrease to 25% of generic drug costs. While in the catastrophic coverage phase, Medicare beneficiaries pay 5% of the cost of their prescription drugs for the remainder of the year. Thus, keeping the patients out of the donut hole is one of the main priorities for Medicare patients. It's very easy to reach the donut hole with polypharmacy. Guidelines. When in doubt, follow the current guidelines for the treatment of a particular disease or symptom. There are thousands of guidelines published. It is the provider's responsibility to keep abreast of new recommendations or changes in guidelines and to incorporate these into their prescribing practices. I use an app called Guidelines Central to look up the latest. I also use Prescriber's Letter to keep me up to date, but it is still important to ensure that the treatment regimen is individualized for the patient. Availability. I use an app called RX Shortages to keep up to date on drug shortages. Interactions. There are very few medications that do not interact with either another medication or a food. Polypharmacy greatly increases the risk for interactions. Some of these interactions are negligible, but some can have life-threatening consequences. It is of crucial importance to ask the patient about all current drugs, including over-the-counter medications and other herbal preparations. Many patients do not consider over-the-counter or alternative pharmaceuticals as medications and may not mention them unless you ask specifically. Because my office does not have electronic prescribing, I have two interaction checkers that I use. The first is Lexicomp, and the second is in an app called RX Pocket Pharmacist. When you add a new medication, you need to check for significant interactions. If there is a low-risk interaction identified, you may find it acceptable to discuss this with your patient. Document the conversation and then prescribe the medication. If there's a relative or absolute contraindication to the proposed drug combination, it's best to choose an alternative if at all possible. Side effects. All drugs have side effects. It is important to note the most common side effects for each drug and inform the patient. Allergies. Always check the patient allergies and what the allergic reaction was. Some allergies are actually side effects and not allergies. In case of a severe allergy, such as anaphylaxis or swelling of the face, these drugs are absolutely contraindicated. I would refer anyone who thinks that they have a penicillin allergy to an immunologist. Greater than 90% of people with penicillin allergies do not actually have a true allergy. Liver and renal function. Many drugs are metabolized and eliminated by the liver and kidneys. If these systems are impaired, this can lead to increased adverse effects and possible medication overdose. Frequently, drugs have special decreased doses or different dosing schedules for patients with liver or renal impairment. This is known as hepatic dosing or renal dosing. Always know what the patient's latest liver function tests and BUN and creatinine are. Need for monitoring. Some drugs require frequent monitoring at initiation or throughout the duration of treatment. Some examples of these medications include warfarin and levothyroxine, among others. When levels of these drugs are not within therapeutic range, serious patient harm can occur. As a provider, I have to consider if and when a patient will return. I may only give them a 1-month supply of a blood pressure medication to ensure that they return. This is an important balance because some may get angry if they need to return and just won't. Special populations. Will we be talking about this in another chapter? This includes pediatrics, the elderly, pregnancy, and even race. Most research on prescription errors has been done on physicians, and the results over the years has been reasonably consistent. Problems are created in writing up-to-date prescriptions because of physician failure to keep abreast of changes. Information about new products and new research findings diffuse slowly into practice. Pharmaceutical companies influence practice and provide drug samples. When the bulk of information coming to a physician is provided through biased marketing sources, physicians may have a difficult time evaluating the relative merits of competitive products. Lack of time has become a major factor in all medical practices. The emphasis on making money in many health maintenance organizations has led to decreased time for patient encounters, leading to inadequate history taking, failure to clearly define the problem, and an over-reliance on drug therapy. Consumers provide pressure to prescribe medications. Although the interest of consumers in their health care is usually a positive trait, the demand of patients on the physician to do something has translated into an increased insistence by the consumer on being given a prescription. This pressure has increased as a result of the widespread use of direct-to-consumer advertising on TV and in lay magazines. Giving in to these pressures has resulted not only in a society of individuals who tend to take a pill for everything, but also in the widespread overuse of antibiotics, thus contributing to the problems caused by drug-resistant organisms. Most revealing was the research that showed when patients asked for a specific prescription, most of the time they received it. Prescriptions are often illegible. Pharmacists report great difficulty in accurately reading the writing of many physicians. This has led to major errors in dispensing of medications as they try to determine what the physician might have written. Use of pre-printed prescription pads, fax machines, and computer-generated forms will help to decrease these problems. The current federal mandate for electronic medical records and electronic transmission of prescriptions for Medicare providers will set the trend for other healthcare insurers. The Joint Commission has issued requirements for its accredited organizations to avoid using abbreviations for certain drugs, drug dosing frequency, and how drug dosages are written in order to reduce prescribing errors. Providers may fail to detect or anticipate drug interactions. Lack of provider awareness about the influence of different drugs on the liver cytochrome P450 enzyme pathways has meant that the drug-drug interactions have made many medications ineffective. Over 5 million times each year, one of the nation's largest real-time computer systems alerts American pharmacists that the drug combinations they prescribed could trigger potentially lethal interactions. An even greater challenge is the growing use of over-the-counter and herbal products. Often the patient's physician is unaware of this usage, and many of these products do interact with prescription drugs. There is a separate presentation on how to write a prescription by Dr. Kate Coulter. It is full of important information. For most assignments in the class, you will need to write a prescription to go along with the assignment. Thus, the additional video is very important. There are basic components that should be included when teaching about any new medication. The patients need to know the name of the medication they are taking. I often have patients who do not have a list of their medications, and when questioned, they refer to medications by their understood purpose, like a blood pressure pill, rather than by their name or a description of the pill as a little blue pill. Knowing the reason the medication is prescribed propels the patient to follow through with the medication plan because the patient is aware that this action helps to achieve the therapeutic goal. I can't say enough about patient education for heart failure and hypertension. Patients do not feel better when taking these medications and need to understand the purpose in prevention. The dosing schedule needs to be reviewed with the patient, even though it is written on the prescription label. Doing this ensures that the patient understands how to take the medication and provides an opportunity for the patient to ask questions. Many patients are told that they need to take their statin for hyperlipidemia at night. This is true for a few select statins and not the most frequently indicated statins in the current guidelines. A common patient concern is whether medication should be taken with or without food. This routine information should be provided for all drugs. Inhalers should be reviewed specifically. We have several teaching inhalers provided by the drug manufacturers in the office to demonstrate. One of the things that I like best about Lexicomp is that it lists the frequency of the side effects, so know the common ones and how frequently they occur. Some providers and other healthcare workers hesitate to discuss a drug's potential adverse effects. Healthcare providers are ethically obligated to divulge adverse effects and other risks, but some are reluctant to discuss them with the patient. Now that TV and radio ads are required to list side effects, patients worry about taking drugs that list dozens of adverse effects. Most side effects occur in less than 1 to 2% of patients, and the incidence of side effects in the placebo group may be almost as high. Let patients know that many adverse effects, most commonly nausea and sedation, are usually temporary and go away with continued medication use. Emphasize the benefits over the risks. Patients need to know any special storage requirements, such as if the drug needs to be refrigerated or cannot be exposed to light. For example, some antibiotic suspensions, insulins, and rectal suppositories need to be refrigerated. Medications such as sublingual nitroglycerin and dabigatran, which is Pradaxa, needs to be stored in their original container to prevent drug breakdown and loss of potency due to exposure to light. Liver enzymes may need to be checked periodically for drugs that can cause liver damage, and serum drug levels may need to be checked when maintaining therapeutic levels. Many medications interact with certain foods or other drugs, including alcohol. They need to know if they must avoid the interacting food or drug completely or just for a few hours before or after taking the drug. For example, antacids may be taken with most drugs as long as administration is separated by 2 hours. However, patients taking metronidazole must avoid alcohol for the duration of therapy since this is related to antabuse. Failure to recognize the need for prolonged therapy is a common reason for patients to stop medications prematurely when a prescription runs out. For antibiotics, they need to know to finish the entire prescription, even if feeling better. If being prescribed a long-term medication, they need to know this too. Medication non-adherence in the U.S. costs approximately $290 billion a year, as it's often directly responsible for disease exacerbations, avoidable hospitalizations, transitioning to long-term care, and premature deaths. For example, think about heart failure and the effort that hospitals put into preventing readmission. Heart failure patients' medications may be costly and confusing. The heart failure patients often do not know which foods are high in salt, and they fail to weigh themselves every day. Medication adherence can be defined as the extent to which patients take their medications as prescribed by the provider and agreed to by the patient. Thus, if they are non-adherent, they fail to take the medication at the prescribed dose, frequency, or length of time, if at all. These are the reasons that patients gave for non-adherence in a 2013 study by the National Community Pharmacists Association. 42% of the patients say they forgot to take it. This is one of the reasons why we try to decrease the frequency of a prescription if possible. It is much easier to remember to take a prescription once a day than it is to take it 3 or 4 times a day. 34% of the patients say they ran out. We have patients that know that they are about to run out, so they start taking the medication every other day until they can make it to the pharmacy. With birth control pills, this often leads to pregnancy. 27% say they were away from home. Personally, I think this must apply more often to men than women because women have purses and usually have backup pills in their purse. 22% said they were trying to save money. Medications are expensive, and I'm surprised this reason isn't higher up the list for non-adherence. It's difficult for patients to afford medications on a fixed income, especially if they have multiple prescriptions. But I also see that paying for prescriptions is not necessarily a priority. I see patients who say they cannot afford the medication, but then pull out the latest iPhone, and I'm using an iPhone that's 3 versions earlier. 21% said they didn't like the side effects, so they stopped the medication rather than calling the healthcare provider. Perhaps the side effects were from taking the medication on an empty stomach, or maybe they needed to take the medication at a different time of day. 17% said they were too busy to take their medication. This reason may account for multiple other reasons, such as not having time to get it from the pharmacy or not having time for the follow-up with the healthcare provider. I had a patient just the other day who had stopped taking his blood pressure medication over a year ago. He didn't understand the long-term effects of high blood pressure. 17% said the medication wasn't working. Often medications are needed when there's no clear result that can be seen by the patient. In the blood pressure scenario, patients can only tell if the medication is working if their blood pressure goes down. But they do not feel any better when their blood pressure is down, so why take the medication? As a prescriber, you must think of what else you could have done to prevent the patient non-adherence. In summary, prescribing is a very important responsibility. The wrong prescription can be lethal. A thorough medication history is essential. Multiple factors need to be considered when selecting a medication. You must stay up to date to be competent. Part of the duty in prescribing is patient education. Knowing how to write a prescription avoids errors. And all of the above can help avoid some instances of non-adherence.